You on 8?
You on 8?
Okay, you're clear. Stand by for your base. Clear, number 2, go ahead.
Welcome to EMS Cast, where we provide high-level education for you, the providers on the streets. I'm your host, Ross Orpit, and first, a message from legal. The views expressed on this episode are the views solely of that of the host and those individuals being interviewed. They do not reflect the views of their respective employers. Now, the episode. Today we have a very special episode. We're going to hear from a good friend.
My name's Glen Andrews.
Glen is a seasoned paramedic with over 3 decades of experience. He's worked in a variety of settings, from ambulances to hospitals to classrooms and backcountry settings, including search and rescue and ski patrol.
Before I moved out here to Colorado, I was an ophthalmic dispenser out of New York City and found that profession to not be quite as exciting, and got into EMS at Clear Creek County Alpine Rescue Team, 1986. Started with Clear Creek Ambulance, got a full-time job over in Summit County Ambulance, and ended up being a Dr. Gordon prodigy out of St. Anthony's, one of the early programs here in Denver.
Glen, thanks for coming on. I'm really excited to have you on the podcast today. I've been really looking forward to this episode and hearing from you. You are a ACLS instructor. You teach, how many courses a year?
I teach a couple hundred, actually. I've been with a lady named Midge Burrows, who owns EdCore now, for 28 years.
Wow. Okay. So you teach a couple hundred ACLS classes a year.
Couple hundred.
And something very unique happened to you. How long ago now?
Well, it was July 21st, 2020 was the start of my story here.
Take us through that day. What happened on July 21st?
Well, let's back up a week before. I was up in the wilderness, Indian wilderness range up around Loch Lomond, running around tree line, having a good time. No shortness of breath, no discomfort.
The week before July 21st, Glen was hiking in the wilderness, feeling great. He's normally a pretty active guy, having participated on search and rescue and ski patrol for a lot of his adult life. And then he returned to work just as usual.
Worked my Sunday and Monday shift, as I do normally, 7 to 7 at University of Colorado. And that day we just happened to be having a very high volume day. And there was a little drama at work. And every night after the shift, we go up to the 15th floor, which is 2 floors above the helipad, and always take some new employees or some employees with us. There's a walk up Everest, where if you do it 37 times, it's the distance of Everest. And a lot of people have prayer flags up there, and a lot of goals have been met up there.
Glen had just finished 2 grueling and busy days in the emergency department. These were stressful days, but still he ended each day with a walk up to the 15th floor of the hospital. He was feeling fine when he left work, but when he got home, something changed.
When I got home, I felt a little pain in my rhomboids, and then I had a zing right here in my pectoralis muscles. It was like a little electrical jab.
As one does, Glen begins to explain away the feelings he's experiencing.
I was thinking that we had been doing a lot of push-ups, and I was kind of amazed that I was getting this kind of soreness, since we had been working out for a couple of weeks, if not months. And it just felt like a soreness, but instead of just having one side, it was a quick zing right where your deltoids and your pectoralis meet.
Had you ever felt anything like this before?
Never felt like anything like that before. So I took a little Advil and a half of a Zolpidem and decided to call it a night, because I had to work the next morning, a 7 a.m. shift.
You had these odd pains that you've never felt before, and you took some Advil and some...
Yeah, some Zolpidem. I was just going to kind of sleep it off and get ready to go back and get beat up in the emergency department.
Glenn went to bed thinking he was just going to sleep this off.
And then I got up like at 2 o'clock in the morning, and I thought maybe I'll go do a GI cocktail. I have history of esophageal reflux and had taken some omeprazole the night before. And when I got down to the refrigerator, I noticed I had my left hand kind of behind my head, like I was in a half Nelson. I was the only one downstairs, and I kind of said to myself, "Why do you have your hand behind your head?" And a little guy on my shoulder said, "It's because your left arm really hurts bad."
And what were you thinking at that moment? You now have these, were you still having that pain in your kind of pec delt region?
No, I didn't have that. I had more of this esophageal discomfort that I had thought it was GERD. And Wendy, who is a nurse up at Broomfield, had listened to me complain about the events at the day before, and I went upstairs and I woke her up and I said, this GERD discomfort is a little bit different. So she walked down and I continued to do a little viscous lidocaine and some Maalox, and by now this discomfort had developed into some kind of like chest tightness.
So at this point, Glenn starts to realize this pain is different. It's not a normal soreness from working out. It's not his normal GERD. In fact, it's not like any discomfort he's really ever felt before. And so what does he do? Does he call 911? No, of course not.
Well, like any good paramedic, I went to the medicine cabinet and chewed 481 milligram chewable aspirin. And I got a great idea of, since I have a bunch of mannequins and ACLS stuff out in the garage, I should go out and get my Zol M series and bring it upstairs and do a little 12 lead on myself.
Okay, so you've started to think this is a different pain than my normal GERD. I'm a little concerned about this pain. I'm a little concerned to the point where I'm going to take some baby aspirin. But rather than call 911, you decide, hey, I have a 12 lead monitor. Maybe I'll just hook myself up.
Exactly. And in the hindsight, I wouldn't really recommend this type of denial, but it was my denial. And so went and did proper Einthoven's triangle to make sure we got a nice tracing, and my 2-3 in AVL looked pretty good. I was a little bit more tachycardic, not bradycardic, and got leads. I was in lead 3, so shooting off of a V lead, I was looking at lead V3 and V4. And
so this monitor, is this monitor just have 4 leads then? Or are you just moving these 4 leads around to different locations?
Yeah, we actually call it a hasty 12 lead, where we look at 1, 2, and 3 using Einthoven's triangle. And when you're in lead 3, you can actually shoot true V leads.
Okay, so describe this to me. You have a 4 lead monitor, which normally hooks up to your right arm, right leg, left leg. And you're now taking one of these leads. Which lead are you using to move around the different precordial leads?
Well, I'm in lead 3.
What is that? Which leg? Like, which extremity is that?
So lead 3 is plus 120 looking to the right. And as we move the red lead across the precordial, it actually gives us a true V lead. If I had stayed in lead 2, I would have got the same results, but we would have called that a modified chest lead.
Okay, so if I'm recalling my days from being a paramedic, I'm using my mnemonic. It's white on right, smoke over fire. So the white lead goes on the right side, the smoke, which is the black lead, goes on the left arm, over the fire, which is the red lead, on the left leg. So you're taking that left leg and you're moving it around the precordium.
Yes.
Gotcha.
But I've moved the monitor lead into lead 3.
Okay, so on the monitor, you're looking at lead 3 and you're moving that left leg or that red lead around.
Yes. And I thought to myself, man, I must have this hooked up to a simulator.
Why? What were you seeing?
Well, I was seeing not necessarily ST elevation in the beginning, but it was more of hyperacute T waves. And by now, this discomfort was really starting to overcome myself. So I turned the monitor off, thinking that that when I turned it back on, just like turning on a vacuum cleaner, I might get some better results.
V3 and V4, you initially noticed you said a hyperacute T wave. Describe, what did this T wave look like?
It was hyperacute. So it wasn't pointing like a T wave, but you could tell that it was different. That's why I thought by turning off the monitor and resetting it and make sure that my amplitude was set at 1.5, that everything was going to be fine.
Maybe it was just a filter.
Yeah, it was just a filter thing.
Okay.
And when I turned it back on, the J point elevation had developed more of ST segments in my anterior leads.
Like troubleshooting a computer that's malfunctioning, Glenn follows every IT specialist's first piece of advice, and he turns the equipment off and back on again, thinking this would fix the problem. But instead of fixing the problem, things now look worse. He wasn't just seeing hyperacute T waves now, he was starting to see some concerning J point elevation.
Well, it was ST elevated about 2 to 3 millimeters, and I had come to the conclusion that I didn't accidentally have it hooked up to a simulator. And by that time, I know through my teaching, I have talked about strokes and acute chest discomfort about calling 911. So we called Arvada Fire, and I think I took a quick shower real fast, just in
Gotta look pretty for those firefighters.
Yeah, look pretty for the firefighters. And I was thinking to myself, after taking care of so many hundreds or if not thousands of these type patients, what I was actually experiencing was denial, and that I was getting ready to surrender all my training and all my knowledge. And luckily my denial was only 40 minutes.
What was your pain like at this time? What were you feeling as you're going through this 12 lead on yourself?
So a lot of times with myocardial ischemia, the proper wording is not pain. It was a tremendous amount of pressure. And as we had discussed earlier, the scale of 1 to 10 works for a kidney stone or a broken leg. My discomfort, the squeezing and not able to take a deep breath was closing the 50 mark. It was very, very uncomfortable, and a tightness that I had never experienced before.
So this was like a discomfort that you've never experienced. And I think you said something very important there, and I've experienced this myself as I've treated patients with ST elevation MIs. Is we often talk about chest pain, and when you're talking to the patient, we often just reflexively ask them, like, how is your pain? But you're saying this felt very different from like I just cut my arm or I just broke my bone. This was not like a sharp pain. This was like a very different feeling you were experiencing.
Exactly. The discomfort was such an intense squeezing of the circumferential of the whole chest. And I was slightly diaphoretic. And now, as you know, with any patient that's sick, you get that small bit of anxiety. Okay. That I was surrendering, and I knew something now, that my body was telling me something that I had never felt before.
Okay. So you're feeling this squeezing that you've never experienced anything like it.
The most intense thing, Ross, I've ever felt in my life.
Okay. Incredibly uncomfortable. Was it still radiating?
It was constant. It wasn't intermittent anymore. I had determined that this was not esophageal reflux disease, and being with all my years in the ambulance, I was very comfortable when the ambulance drove up to walk right in back of the ambulance. I was in my boxers. I didn't decide to get dressed because I promote having people in gowns and
you'd make the job of the nurses a little easier.
Yeah, the paramedics, and I know a lot of the Arvada guys, and the paramedic asked me what's wrong, and I said I think something's wrong with my LAD.
Wow. Okay. And then what happened? What did the paramedics do?
Well, they checked my blood pressure, and of course they checked it bilaterally because as a young person with no history of coronary artery disease, and even though I wasn't having back discomfort, this could be an indication of a root dissection. So they went ahead and started an IV on me, which one missed, and I was very proud when the female firefighter put a 16 gauge in my right forearm, and they hooked up a little bit of fluids and did the 12 lead and handed me the 12 lead, and I asked them if we're running hot or routine.
Okay, and what did that 12 lead look like to you?
Well, the paramedic handed me the 12 lead, and of course I could see that this was real, and all through ACLS and stuff, we practice interpreting EKGs, especially in the worst lead 2, but looking at 12 lead patterns. And I knew that when they put the pads on me that had the feedback puck on the lower third of my sternum, that this was not a training situation. And I asked where I was being taken, and they had told me that Lutheran was the best place to perform PCI.
At this moment, Glenn can no longer deny what's going on. Staring at his own 12 lead, realization finally sinks in that without a doubt, he is having a STEMI. He has spent the good majority of his career treating patients having an MI. For something like the last 2 decades, he has taught all kinds of providers in over 200 classes a year how to recognize this and act fast. And here he is now on the bed instead of standing over the bed, a patient himself.
And my kid was sitting out and at the car, and I was thinking, a lot of our patients that come in from DIA have an arrhythmia, and that's it. And it was my first time I'd ever really been faced with death, the possibility that I might have an arrhythmia going in, and that will be the last thing that I remember.
The ambulance doors close, and they begin running lights and sirens to the closest cath lab. En route, Glenn gets nitro, but maybe somewhat surprisingly, that doesn't seem to be what gives him the most amount of relief.
Yep, they after we got the 12 lead and knowing that it wasn't an inferior or right ventricular involvement, and I was a little hypertensive, they did give me 0.4 sublingual, but I think the best was the 100 micrograms of fentanyl. It allowed me some time to think. I think in the emergency department, we're so fast on you need to answer all of our questions and click all the boxes before we give you any pain meds. And I would have loved to answer all the questions, but when the chest tightness, that squeezing circumferential in your chest is approaching a scale of 50, you need that analgesic to let you breathe and actually think about the situation that's going on.
Almost like your mind couldn't focus on anything other than that discomfort right then and there.
Yeah, it wasn't my mind, it was my body telling me something is really, really going on.
So what did that 0.4 of nitro do for you? Anything?
I'm sure it caused a little coronary vasodilation, but what I do remember is the almost instant relief of the 100 micrograms of fentanyl.
Interesting.
It gave me enough time to be able to answer questions, and I knew that we were running emergent, and I remember looking out the back and seeing that we were going past the Costco there at 52nd and Wadsworth. So I knew that 38th and Wadsworth and Lutheran were pretty close.
Anything during that transport that stood out to you?
Well, the paramedics gave me a lot of insurance and reassurance. I remember there were 3 people in the back, and I'm sure that one person was ready to jump on that feedback device if there was an arrhythmia. And I remember them notifying the hospital, which is one of the big dynamics of advanced cardiac life support, is pre-hospital notification for burn alert, OB alert, stroke alert, trauma alert, in this case, a cardiac alert. So I knew a hospital report was given, and that I would be the guy that usually receives the care is now going to be the guy that's going to be on the other end of the care.
Talk to me what it was like to be on the other end of that care. How did you perceive that reception and what was going on around you and the treatments that were going on?
Well, in the first, when we first called 911, it was a great sense of what I described as surrendering, that I had always been the person giving care, and now I'm calling 911 and not having someone drive me to the emergency department, and giving all my years of experience to the Arvada Fire Department. About 6 months prior, our little ACLS company had done ACLS for the cardiovascular team down at Lutheran. So when I first rolled in, Scott Valent, the chief plumber, the interventional cardiologist, grabbed my hand and he said, "I'm not planning on doing ACLS tonight." I said, "Please, let's not."
Wow. So did they get you up to the cath lab pretty quickly then?
They got me up. Door to balloon was 15 minutes. They did give me some more pain medicine. I think they gave me some nitro. They shot a quick sitting AP, got a secondary IV on me, and I was able to keep my phone unknowingly into the cath lab, because I ended up having a bunch of pictures of myself and the monitor there going into the cath lab, and I remember getting some intake, and I believe the art line was getting ready to go in my right radius, and I must have got some Versed, and that's about all I remember.
And what did they find?
Well, when they got in, I had a distal lesion on my LAD, and I had some other coronary artery disease in my other arteries, not enough to open, but they did put a stent in my LAD, and I woke up in the cardiac cath lab thinking like my life changed. And being up of land up in Fairplay and being up in the mountains the weeks before, and just running around with no hint of any sort of cardiovascular disease, and within hours my life had changed. If this had happened 6 hours before, I would have still been at work at University Hospital.
And how has your life been since this event?
Well, Ross, the very first 4 or 5 months, when you get scared, you do stuff like buy a Zoll AED Plus, because you want to be able to travel up to the mountains and do stuff. But I think being scared, which cardiac rehab helped me get over being scared, and knowing that I could do stuff, and I wasn't going to have a lethal arrhythmia, and make sure that the people around me know that yes, not only do we have a Zoll M series, but we have a Zoll AED Plus, which is out in your driveway if something happens now, that we can use for other people and or myself. This past year, I work. I'm one of the paid paramedics up at Loveland ski area, and just being up there and doing the morning checks and stuff, slowly I got over kind of the fear of what post-MI brings to you, as being scared about doing everything. I would take the trash out at night, and I would say, if I don't come back in like a minute, please come check on me, or I'm pulling into Lowe's and I'm going to be walking, carrying some wood. If I don't call you in like 5 minutes. It was being scared is a huge part of it.
Wow. So you work as a paramedic at Loveland Ski Area. You work as a paramedic at the University of Hospital here in Colorado, and you teach ACLS. How has this experience changed how you do your work or how you view your work?
Well, one thing it gave me after I came to a full conclusion is that I have wisdom and knowledge. As a educator and a 28-year veteran of teaching advanced cardiac life support, now I've been on both sides. We all know about treating algorithms and doing our tachycardia and our bradycardia and our acute coronary syndrome. But until you've been on both sides, it's really about, for me now, the trusting those patients and the nurses that were caring for you.
Is there anything that you've learned from this, going through this yourself, that you would hope to impart on other paramedics out there?
I think whether it's paramedics or family, when your family members or your friends have this chest discomfort or stroke type symptoms, you have to either, if you're in the UK, call 999, Europe 112, or here in the US 911, and be evaluated at a facility that can handle acute coronary events or cerebral events. Because a lot of people do what I did, and luckily my denial was only 40 minutes. And looking back, I knew something when I took the aspirin and I reconfirmed by doing my own 12 lead. Might not have been the best judgment at the time, but I would think 99.8% of the people aren't going to have that option. And to use the emergency services appropriately. And hopefully you're not having an MI and you're not having a stroke, but there's one way to really evaluate that is to have an exam and an evaluation at a facility.
Caring for these patients, it's difficult because we can't be in their shoes. We can't truly feel what they're feeling. Obviously, you described this sensation of feeling this extreme discomfort that you couldn't focus on anything else, and it was unlike anything you've ever felt before. But as providers, we can't put ourselves in those patients' shoes. And so something that I always teach early providers is that make the patient prove to you that they're not sick. Take everybody's chief complaint at face value and work it up and prove yourself either through your history and physical exam or through the tools that you have, like your monitors and your labs, and prove to yourself that they're not sick before you dismiss that patient.
Exactly. Because I was the last person to think that I had just done 15 floors of the stairs at university and came home and absolutely had no symptoms. Now, if we back up a while, I was in Spain for the month of February, which I came back either from Spain or at the U. I got very sick with COVID-19. And this happened maybe 4 to 6 weeks after I had recovered. So I had some shortness of breath and body aches and fevers and stuff prior than that, but I did not seek emergency care for that.
Yeah, this is something that was so different to you that caused you to be so concerned that you called 911. Despite having all of your knowledge and all of these other symptoms, that you're able to avoid going to the emergency department. Something about this was different, which is why it's so important when somebody does call you on the ambulance. Something is potentially different that day that you need to make sure is not going on. It's not something life-threatening.
Exactly. And a lot of times in the old days, we used to say another drunk attitude's another drunk lawsuit. And these patients, we're all human and they deserve a decent ALS or physician level exam. And if we see something and the patient still wants to refuse, we have the ability to call base contact and give them their options that this could result in death. But in someone like my situation and the MIs that that we've seen since that, they're seeking emergency care because their body is telling them that this chest tightness, this squeezing, this elephant on their chest is very uncomfortable.
Thank you so much, Glenn, for coming on to chat with us today. Is there anything else you want to say before we finish today?
Well, I just want to say for all of you EMS people out there, we're under a lot of stress right now, and especially with the COVID and the clotting. And keep an eye on your health and your cholesterol and your symptoms, because the latter part could have been sudden cardiac death. And pay attention to your body, and don't be afraid to surrender or call for help when you feel that you need it. So thank you, Ross, for having me and listening to my story.
Thanks, Glenn. I'm so happy that you're here today to be able to tell me this story and that you called 911 that day.